We'll move on to the next speaker. Next speaker is Dr. Gayani Ranaweera. She is a consultant histopathologist and a senior lecturer in pathology at Faculty of Medicine, Colombo, and her research interests include gynecological pathology, endocrinology, and hematolymphoid pathology. She is also a council member of the Sri Lankan College of Pathologists, as well as a fellow of the Royal College of Pathologists. Her presentation is on molecular subtyping of endometrial cancer. It's a new concept for this country. Molecular subtyping of endometrial cancer. Over to you, Gayani.
Good morning. I'm Dr. Gayani Ranaweera from the Department of Pathology, Faculty of Medicine, Colombo. And in this presentation, I would be speaking about the novel molecular classification of endometrial carcinoma. I'd like to start this presentation by very briefly recapitulating how currently we determine the prognosis and management of endometrial carcinoma. And this will lead us to the discussion why there is a need for a molecular classification. And then I would discuss the proposed molecular classification of endometrial carcinoma, and finally the potential implications of molecular classification on prognosis and management of endometrial carcinoma. Endometrial carcinoma is a fairly common gynecological malignancy. In fact, it is the most prevalent gynecological malignancy diagnosed in most parts of the world. Most women with endometrial cancers will have a good prognosis. This is because many of the women who present with endometrial cancers, they present at early stage disease. However, if someone presents at advanced disease or if someone has recurrent disease, the prognosis is not so good. Currently, the prognosis and treatment of endometrial cancer are mainly decided by the information derived from histological examination of these tumors. These include the tumor type, the tumor grade, the pathological tumor stage, and presence or absence of lymphovascular invasion. And these parameters will in turn decide the type of surgery a patient would be offered, the type of adjuvant therapy that would be offered, and also how often a patient would be followed up. As we all know, the endometrial carcinomas are subtyped by microscopic examination of the tumor, sometimes facilitated by immunohistochemistry. The most commonly encountered endometrial carcinomas belong to the endometrioid subtype, followed by serous and clear cell carcinomas. Unlike in the ovary, all serous carcinomas of the endometrium are considered high grade, as well as clear cell carcinomas. We also call these tumors type 2 tumors. Tumors of the endometrioid subtype are further assigned a FIGO grade depending on how differentiated they look on their morphological appearance. So grade 1 and 2 tumors are considered low grade tumors, and these are also called type 1 tumors. And grade 3 endometrioid carcinomas are considered high grade or type 2 tumors. However, over the years, people identified certain limitations of these current criteria that are mainly derived from histologic examination of these tumors. On one hand, studies described significant interobserver variation when subtyping and grading these tumors. On the other hand, there were these occasional tumors that appeared deceptively low grade but showing aggressive biological behavior, and also those tumors which appeared high grade but behaved in a quite an indolent manner. So this highlighted the necessity for a more objective classification for endometrial carcinomas to avoid possible overtreatment or undertreatment of these tumors. And it was this necessity that paved the way towards the molecular classification of endometrial carcinomas. The classification that is widely accepted today is the one proposed by the Cancer Genome Atlas project in 2013. This classification stratifies endometrial carcinomas into 4 prognostic groups based on genomic features. And in the next part of this presentation, I will be discussing each of these prognostic groups in a little more detail. The first group of tumors in this classification are the polyultramutated endometrial carcinomas. These tumors are characterized by mutations in the exonuclease domain of DNA polymerase epsilon, thus the name poly. And because of these mutations, the proofreading abilities during DNA replication are suppressed, thus causing increased replicative error rates and resulting in the ultramutated phenotype. Polymutated endometrial carcinomas comprise approximately 10% of all endometrial carcinomas. Polyultramutated endometrial carcinomas tend to occur in relatively young females with normal body mass index, and they also tend to occur as early stage disease. Histologically, almost all these tumors are endometrioid type tumors, and they are typically grade 3 tumors. And on histological examination, actually these tumors look quite scary because they are grade 3 tumors, and they also are known to show frequent lymphovascular invasion, and some of these tumors can contain tumor giant cells. The other histological features of these tumors include tumor infiltrating lymphocytes or peritumoral lymphocytic aggregates, and these tumors are known to invade with a broad front of invasion. And now, going by our traditional criteria, these tumors look quite aggressive, and therefore we would think that these are potentially candidates for receiving more aggressive surgical staging or aggressive adjuvant therapy. However, multiple studies have pointed out that ultramutated endometrial carcinomas have an excellent prognosis, and this is true even for high-risk tumors. And also, recurrences or metastatic disease are also very rare in this group of tumors. We don't know the exact reason for this phenomenon. Some people think that these tumors are very sensitive to adjuvant therapy, and that's why they have a good prognosis. And there's a second school of thought where they think that these tumors possess intrinsic characteristics that are beneficial for survival, independent of the sensitivity to adjuvant therapy. In fact, this second school of thought is supported by the molecular analysis of the tumors, which were originally recruited for PORTEC Trial 1. And it is also suggested that polymutant endometrial carcinomas are immunogenic due to their high mutational load, leading to the lower rates of recurrences that are observed. This raises the question whether patients with polymutated tumors are receiving unnecessary aggressive treatment at present. And in fact, treatment de-escalation for patients with polymutant endometrial carcinomas has been proposed. This notion is supported by the molecular analysis of the tumors which were included in PORTEC 3 trial, at least for high-risk cancers which were polymutant. And the results of the ongoing PORTEC 4A trial will show if this is a valid approach for patients with intermediate risk polymutant endometrial carcinomas. And also, we already know that polymutant carcinomas are unlikely to recur or show metastatic spread. But in the event this happens, immune checkpoint inhibitors may have a place in these kind of tumors. The second subtype of tumors in the molecular classification is the hypermutated carcinomas with microsatellite instability. These tumors comprise 25 to 30% of all endometrial carcinomas, and these tumors arise from defects in post-replicative DNA mismatch repair system. And this can result from either an inherited cancer syndrome like Lynch syndrome, where there's a germline mutation, or it could be from acquired or somatic mutations. But more commonly, this happens because of epigenetic events. For example, methylation of one of the genes involved in mismatched DNA repair. The most common gene to undergo this is the MLH1 gene. Around 75% of the tumors with microsatellite instability occur as sporadic tumors, and most of the rest are associated with Lynch syndrome. And lower uterine segment involvement is also common in this group of tumors. Histologically, most of these tumors are endometrioid type, and a large proportion of these are again grade 3 tumors. And similar to what is seen in polymutated carcinomas, these tumors will also show tumor infiltrating lymphocytes and frequent lymphovascular invasion. So there are many histological features that are shared between the tumors with microsatellite instability and polymutated tumors. But in contrast to polymutated tumors, the prognosis of tumors with microsatellite instability are more guarded, and it's described as intermediate. The next subtype of the molecular classification is the copy number high subgroup with frequent p53 mutations. These tumors usually occur in females with advanced age, and they also tend to present at a higher stage. And these females have normal BMI usually. Histologically, almost all the serous carcinomas that occur in the uterus fall into this category. But not only serous carcinomas, a proportion of endometrioid carcinomas can also show p53 mutations. Around 20% of grade 3 endometrioid carcinomas will fall into this category, as well as a minor proportion of what we consider low-grade endometrial carcinomas also can show p53 mutations. These tumors tend to show destructive pattern of invasion and also frequent lymphovascular invasion. And the prognosis of these tumors are considered poor. The last category in the molecular classification of endometrial tumors is the copy number low subgroup. These tumors will not have a polymutation, they will not have a p53 mutation, and they are microsatellite stable. And histologically, almost all of these tumors are endometrioid subtype, and the vast majority are low-grade endometrioid type carcinomas. And these show frequent ER/PR expression, and they can show squamous differentiation. And in other words, these are the tumors what we will consider as type 1 tumors in the current classification. And these tumors are known to have a good prognosis with lower risk of metastatic disease. So in summary, the molecular classification identifies 4 distinct subgroups of endometrial carcinomas with different clinical pathological profiles and implications for prognosis and management. And importantly, these subgroups cannot be reliably diagnosed on morphological evaluation alone. Now, there's not much doubt on the potential usefulness of the molecular classification on risk stratification of endometrial cancers. But how practical is it to use this in our routine diagnostic work? The methods used to subcategorize these tumors in the Cancer Genome Atlas project are neither practical or cost-effective in the routine diagnostic setup. To circumvent this problem, 2 research groups have proposed methodologies that can be applied on routine formalin-fixed paraffin-embedded material. These are the most popular algorithms that have been put forward for this, and these methods use immunohistochemistry. They use immunohistochemistry as surrogates for genetic analysis, except for the detection of polymutated carcinomas, which of course will need either Sanger sequencing or next generation sequencing. Now let's look at the impact of molecular classification on management of endometrial cancer. According to current evidence, the impact is principally on women with intermediate to high risk disease. This is because we don't have enough evidence to decide how this translates into management of low risk disease yet. And therefore, at least for now, this calls for identifying high risk patients based on conventional pathology and selectively testing them for molecular signature of their tumor. For example, in a grade 3 endometrioid type carcinoma diagnosed by conventional methods, depending on whether the patient has a polymutation or whether that tumor is microsatellite unstable, or whether it has a p53 mutation, the subsequent management of this patient may differ at multiple different levels. For example, if we consider preoperative decision making, if the patient has a polymutation, she can probably be spared of aggressive surgical staging. Or if she is a young patient with fertility wishes, uh, even fertility sparing management could be considered, but not if she has a p53 mutation or show microsatellite instability. The same applies to proposed operative adjuvant therapy and surveillance as well. And if there's recurrent or metastatic disease, the patients with polymutations or microsatellite instability may benefit from immune checkpoint inhibitor therapy. And if there is microsatellite instability, those patients may also benefit from genetic testing to exclude Lynch syndrome. There are certain challenges that we encounter in this system as well. One such problem is that there are sometimes tumors with more than one mutation. We call these tumors multiple classifiers. For example, you can have a tumor with a polymutation as well as a p53 mutation. Or there could be a tumor with microsatellite instability also showing a p53 mutation or a polymutation. So this brings a problem then to which category these tumors behave and what kind of biological behavior they are likely to show. Around 2 to 3% of endometrial tumors are known to do this. And of course, recent evidence suggests that microsatellite deficiency and polymutations actually supersede p53 alterations in terms of clinical behavior. However, we need more studies to arrive at such solid conclusions. Yet this finding highlights the need to adhere to an established algorithm when testing for molecular signature of a given tumor to avoid missing these multiple classifiers. Second problem that we encounter is the rare histotypes, such as clear cell carcinomas, carcinosarcomas, and maybe undifferentiated carcinomas, and so on. This is because these tumors have not yet been studied enough to draw any conclusions based on their molecular signature. And finally, of course, there's the problem about cost and benefit. So to achieve the best cost-benefit balance, we probably have to carefully select tumors which are likely to benefit from the information derived from the molecular classification. So will this classification replace the good old pathologist? Well, not yet, but it seems that the molecular classification is here to stay. Probably not as a standalone test, but integrated with traditional clinicopathological parameters. How exactly this will be done is still not clear, but studies are underway, and hopefully we will be armed with more conclusive evidence to achieve this in near future. Thank you very much.
Thank you, Gayani. There are a couple of questions waiting for you. I'll ask the first questions which are being highlighted here on the screen. This is about the origin of the tumor. Now, the histological types of serous, then mucinous, or serous adenocarcinomas, are they primarily of uterine origin or are they extension from the ovaries?
The question is the serous and mucinous cystadenocarcinoma.
Yes, cystadenocarcinomas, are they primarily coming originating from the uterus, or are they it originated from the ovary and then get extended to the uterus?
Yeah, so if histology reports, the thing is usually we don't talk about cystadenocarcinomas in the uterus. We talk about serous carcinomas, and unlike in the ovary, we don't divide it into two as well. We don't have a high grade and low grade, unlike in the ovary. So if you say a serous carcinoma in the uterus, that is like depending on how we report it, usually serous carcinoma is one entity, it's a high grade entity in the uterus. And we don't usually use the nomenclature cystadenocarcinoma in the uterus. or mucinous cyst adenocarcinoma, that nomenclature is not used for the uterus. So
When you,
probably could be,
when you say mucinous,
mucinous carcinoma is there in the uterus. It's fairly a low-grade tumor usually. It's different to mucinous cyst adenocarcinomas that you get in the ovary. I hope that answers that question.
No, So the second question is, by immunohistochemistry, can you identify mesonephric adenocarcinomas?
Okay, mesonephric adenocarcinoma is a new entity. Actually, we call it mesonephric-like adenocarcinomas. It's not, we are not reporting it yet because it's a very newly identified entity and it's not in the WHO classification yet as well. You can identify, it's a combination of things. Mesonephric-like carcinomas, they have a unique histological set of histological features. So along with that, these tumors are usually P53 wild type and they are ER negative, similar to the profile of clear cell carcinomas of the uterus. But then histologically, when you look at those tumors, they are very much different from each other. So that's how we diagnose them. Yes, you can use immunohistochemistry to diagnose them. But right now, we don't diagnose them because it has not yet come into the classification. It's a brand new tumor that is recently being identified.
Okay. Third question is, now this poly classification facilities, are they available in Sri Lanka, or can we do a classification according to that at the moment?
Right now, no.
No. Okay.
Not even in Sri Lanka, even in the rest of the world, even in UK, they haven't still started reporting endometrial carcinomas according to this classification, not yet. Right now, what they do in UK is they actually they do immunohistochemistry to look for microsatellite instability in all endometrial carcinomas. That is to exclude Lynch syndrome. So no, answer is no, not in Sri Lanka. We don't even do the microsatellite status in our cancers right now. So no, we don't have the facilities right now to do it, and it's not necessary also because it's not incorporated yet into your treatment protocols as well. Okay. So even if we report it according to the classification, the oncologists probably won't. Their guidelines haven't yet evolved to incorporate these changes into the guidelines. So that's one other reason that we are not doing it right now.
Okay, thank you. And the other question is about serous adenocarcinomas. How common is serous adenocarcinomas which P53 wild type? And P53 wild type, is it common? Or, and then the rest is, what is the prognosis of this particular type of tumor with P53 wild type, serous adenocarcinoma?
Usually how we do right now in practice is, if we think there's a serous carcinoma looking from morphological evidence, we would do the P53, and usually the serous carcinomas are P53 mutant. It could be like 3 patterns. You get either null type or your like usual mutant type where you get all the cells are positive, or you can have like another cytoplasmic positive. So if those 3 are, we take them as P53 mutant tumors. So serous are
always P53 mutant, is it?
Almost always. So yes. Usually, if it becomes wild type, how we do in practice right now is we won't call it a serous carcinoma. That's how we do right now practically. Like I can't say like 100% of serous cancers will be P53 mutant, but that's how we categorize tumors. For a uterine tumor to be called a serous carcinoma right now, it should be P53 mutant.
Okay. There are another 2 questions waiting for you. And the one question is, this immunohistochemistry facilities are now available in Sri Lanka. Are you using immunohistochemistry in all type of endometrial cancers for diagnostic purposes?
No, right now, again, as I mentioned in my presentation, this molecular classification just means that it's coming. There's an impending change in
no, what
how
I said,
we
no, asking about.
Yeah,
do you do immunohistochemistry in all patients or in selected people?
selected patients, in short, because like most of the cancers we can subtype according to the current classification on morphologic evaluation alone. So the low-grade endometrial tumors will be subtyped on histologic examination alone. And if the problem comes with the high-grade tumors, grade 3 tumors, then sometimes we have a problem. We don't know whether it's a serous tumor or a endometrioid type 3 tumor. In that instance, we go and do P53 status and ER status usually, and that will help us differentiate whether it's a serous tumor or a grade 3 endometrioid tumor.
Okay. Now,
So
so last question is, I don't know whether you can understand this. This immunohistochemistry, can it be used to identify these molecular subtypes, in the sense you can't identify molecular subtypes with the immunohistochemistry? Is there any compatibility with, but I think what they want to know is if there is any compatibility between IHC and molecular subtyping.
Yes. Yeah, there is like two large studies have been done to identify surrogate markers. They are not exactly those those tumors will behave the same way as explained in the molecular classification. So immunohistochemistry can be done to identify your P53 mutations and microsatellite instability, but not the polymutations. So people are still trying to find out a surrogate marker to identify the polymutation. Not yet. So for the poly alone, you have to do genetic studies for the other 2 years. And then once you do those, the fourth category will be the ones which won't have any of those 3 mutations.
Yeah. Thank you, Gayani, for your excellent presentation and interacting with us to update with the current knowledge of molecular subtyping of endometrial cancer. Thank you very much.
Thank you very much, sir.